Started. Thank you for joining us in what is our last Grand Rounds presentation for the 2023 and 2022-2023 academic year. We will be back in September with the State of the Department. I'm really excited today that we have a group presentation, and I'm particularly grateful that Melanie Bennett and her group stepped in at the very last minute. We unfortunately had a late cancellation, and is able to come speak to us today. And we have an exciting presentation, senior faculty, we have residents. We're going to have really excited. And Melanie and her team are going to talk a little about the Early Intervention Network. So with that being said, let me talk a little bit about Dr. Bennett. So Melanie Bennett is a professor of psychiatry at the University of Maryland School of Medicine. She's the director of the Division of Psychiatric Services Research here. She conducts practice-based research to test and implement services that improve health, enhance social functioning, and support mental health recovery for individuals living with serious mental illness. So over the last 10 years, she's been involved in research on services for youth experiencing first episode psychosis. And she is currently part of the training and implementation support services for the Maryland Early Intervention Program, which is a state-funded center of excellence in early psychosis, where she supports early psychosis services implementation in the state of Maryland. A couple of years ago in 2020, Melanie and her team, in collaboration with some colleagues at Hopkins, Shepherd Pratt, Pittsburgh, and Penn, joined the National Institute of Mental Health's Early Psychosis Intervention Network, which is an effort to create a national early psychosis database to support research that will improve practice. And with that, I turn the microphone over to Melanie and her team. Thank you very much.
Great. Thanks, Chris, for that great introduction. I don't know what I want to do. I don't want to share quite yet. So thanks for having us. We were sorry to hear you had a cancellation, but hey, here we are filling in, and people have said, oh, well, what do you have? Well, whatever you hear, it's going to be better than what you would have heard from nobody. So I hope we have some interesting things to tell you about. When Chris and Gloria asked, could somebody from DPSR fill in? It was funny. So I asked my two early career folks. That's what Gloria had suggested. She called them our rising stars, which they certainly are. But in order to be a rising star, you learn not to agree to do grand rounds all by yourself with about a week and a half notice. So I felt proud in a way that both Peter and Sean said that felt like too soon. So I was about to press delete on the email when I said, well, why don't we all just do it? That'll be fun. So we hope to bring you some new information that updates of grand rounds that a bunch of us did 2 years ago on our work in early psychosis. So let me just shout out to the other presenters. I see Peter Phelan first. Peter, can you wave? Peter is an assistant professor in DPSR. Caroline Quieri, could you wave? Caroline and I just met like a month ago, and now we're just in each other's lives. So Caroline is a third-year resident here in psychiatry, and she's going to give, I'll tell you in a minute what she's going to do, but she's part of the presentation. And Richard Goldberg, could you wave? Everybody knows Richard, professor in DPSR. He's the best. And he's going to talk some also. We also had planned to have Bashan Davis, another assistant professor in DPSR, talk to us, but he is out sick. And he is very sorry. Let me tell you, I'm just going to abbreviate his apologies by saying he is very sorry that he is not here. Okay, so now we practiced, so everybody's screens should share. Can everybody see that? Should see a title page? Yes, okay. Let me just open up my boxes a little bit so I can see you all. Okay, so today we're going to tell you about some of our first episode psychosis work, and all of us are going to get at a different angle of what we're doing in terms of creating a learning healthcare system focused on first episode psychosis. Hold on one sec. I feel that I am missing a slide. Anyway, I'll just tell you the slide. So here's what we're going to do. I'm going to give you some background. Then Caroline is going to talk about a recent young person experiencing early psychosis that she found herself working with. She was supervised at least by Maddie Marks, who I see here. Maybe she had some other supervisors, but there was some outreaching between the three of us about what might be a good plan for this person. So Caroline's going to tell about that. Then Richard's going to talk about how we've developed a two-state learning health, some of the activities we've done to develop a system across 2 states and 23 and counting early psychosis treatment programs to bring all of us together, using data, learning from each other, consulting. He's going to tell us a bit about that. And then Peter is going to show us an example of using data collected at the community level to learn something about treatment outcomes. And so we each have about 20 minutes. And so for the rest of the presenters, I'll just trust you know when that is. But if it's coming up to your 20 minutes, I'll just go like this. Okay, so some of you might remember that a bunch of us talked about our department's early psychosis work back in May 2021. And at that time, if you don't remember, but you're dying to know, it was recorded. So it's on our department website, and a bunch of us. So it was me and Howard and Bob Buchanan and Julie Cranbuell and Alicia Luxted. We all talked about various, I guess, milestones in our department's involvement in early psychosis research. So you might remember that we were a site early on in 2008 for the National Institute of Mental Health's recovery after an initial schizophrenia episode initiative, or the RAISE initiative. And that was a big clinical research project. It established the RAISE Connection program, which remains in our Department of Psychiatry and in the Division of Community Psychiatry. And it was a study that involved other sites across the country. And it was really 2 studies, had a lot of sites across the country. And we were really learning about whether early psychosis services worked in America. We had a good amount of evidence that they worked in other countries. So now we wanted to find out if they worked in America, and then the best ways to offer these services. So fast forward a couple of 5, 6, 7 years, and yes, early psychosis services are really good to have, even in America. And there are different models for implementing them, but the model that sort of got codified is providing a lot of person-centered services all together at one location. It's called coordinated specialty care. So you can see it's a intervention that promotes shared decision-making and uses a team of specialists to offer a range of things for the first 2 years of a person's after having an episode of psychosis. The goal being, hit hard, soon, reduce that duration of untreated psychosis. And that seems to be a good mix for many young people to really continue on their developmental trajectory, have good functioning outcomes, good symptom outcomes, and just be doing, living life, doing the things that they want to do. In that grand rounds, we also talked about what happened after that, so that there's usually this research to practice gap where you find something great and then nothing becomes of it. And there was a lot of investment through the Mental Health Block Grant, SAMHSA, and NIMH, invested a lot of time and effort and even money, which was amazing, to have a national program of implementation for coordinated specialty care. And so today we're at a point where there's at least some coordinated specialty care service in, I think, every state. We went from almost nothing around 2000, not almost nothing, but few programs that treated early psychosis. Our own MPRC First Episode Clinic was doing this work long before anybody else was. So there was some places doing this work, but clinically, but very few. To now there's, lots and lots of programs across the country. So a couple of years ago, the National Institute of Mental Health funded 8 sites across the country in what they have called the Early Psychosis Intervention Network, or EpiNet. And we are a regional hub within that network. And the goal was, now we've implemented this, we should learn from it. We've got a lot of this practice going on. How can we learn from that implementation and from all these programs that are providing a service? So the plan, which has actually come to fruition, is to have these regional sites work with community programs to collect a set of common data elements, and eventually to create a national database, right? So all the programs collect data, they provide it de-identified to the hubs, that then provide it de-identified to the National Coordinating Center. So pretty soon there will be a national data set available, first to the hub investigators, but eventually to anybody who wants to use it. So this slide just describes our hub, and you can see there's a cast of a lot of us involved, because there's community coordinated specialty care work going on within Hopkins and within Sheppard Pratt. And we partner with the state of Pennsylvania. So there's a lot going on in all of Pennsylvania, and sort of the 2 state hubs for that work are the University of Pennsylvania and the University of Pittsburgh. And you can see our aims in this project were to figure out how to get all the community programs in our hub collecting what we call a core assessment battery. I'll remind you about that in a minute. Create a 2-state learning healthcare system where we actually do things together and learn from each other and use the data we're collecting in ways that help to improve practice. And then we are also conducting an embedded research project, which I'm not going to talk about here, but maybe in the fall, when somebody drops out of Grand Rounds, Chris will say, Melanie, come back and talk about that cannabis project. And we'll come back and talk about that. So you don't need the details. They're here, and so you'll be able to see them, if you ever come back and look at the slides. But this slide summarizes what we call our core assessment battery. What I want you to take from this is there's a lot of things, and these are being collected by community programs. So put on your researcher hats for a minute and think how hard that is. So researchers are used to going in with their team and collecting the data, and that's pretty hard. But in this, the community programs, the clinicians there and the other staff that run the programs are collecting the data, in addition to all, their regular job, which is providing care. So it's a lot for programs to do. And so it's our job to make sure that it's worth it to them. So we collect a battery that includes a lot of symptom and functioning and recovery measures at admission and every 6 months. And as I said, it's collected as part of clinical practice. We, the research teams, are here to help, but really the programs are determining how things get done. And what programs, there's usually 2 approaches. They use the research team a lot, or they, within their clinical team, divide up what needs to be done and the team works together to do it, or somewhere in between. Okay, so as a set point for moving forward, I thought I'd tell you just the numbers. How big is the data set? This is our hub data set. So as of last week, when it became clear we were presenting at Grand Rounds, there were over 1,000 young people from all these, this is 2 states, represented in the data set. Represented, that means they don't necessarily have all those measures that you saw, but they have some of them at some time, at least one time point. That's what gets you in the data set. So you can see a little bit of descriptive, demographics on those 1,000 people. And then at the bottom, I have some numbers about how that shakes out in different assessment time points. So we have almost 600 people who have the battery at admission. And I call it closed because that doesn't mean it's complete. Programs get 12 weeks to collect it. The 12 weeks, the window ends, and you have what you have in the data set. What's getting exciting is the second and third bullets in that bottom. We're really starting to get a group of people, a good numbers of people who have assessments over time. And that's where the real fun begins. We can see how things change over time or don't change over time. The national data set, as of our last national meeting, which was last month, has over 4,000 people in the data set. So you can see how you can take an issue that has a low rate in the population. And when you pool resources, you can collect a lot of data and so learn a lot of stuff. That's the hope. Okay, Carolyn, I'm handing it off to you.
Okay, can everyone see?
Yep.
All right. So hi, everyone. I'm Caroline Quayeri. I am a third-year psychiatry resident here at the program, and I'm going to be walking you through the work that I've been doing with a 15-year-old patient who we believe is having his first episode of psychosis. I've been working with him at the outpatient child and adolescent psychiatry clinic on Pratt Street with my child and adolescent psychiatry attending Dr. Payne supervising me, as well as my therapy supervisor, Dr. Marks. This case, I think, is really relevant to today's discussion because I've worked with Dr. Bennett and several other of the presenters and people who are joining today for grand rounds because it's been really complicated and it required escalation to reaching out to experts and ultimately referral to a first episode clinic. And it's really highlighted the importance to me of having access to that within your healthcare network. So I'll start off today by taking us back to when I first met this patient, which was in October of 2022. I was told that I was going to be doing an intake with a 15-year-old African-American male coming in with social anxiety on referral from his previous outpatient psychiatrist and therapist who were looking for him to get a more intensive level of therapy and diagnostic clarification. He came to the intake with his mom, and we collected some background psychiatric history, which included having this pre-existing diagnosis of social anxiety, having worked with a therapist and psychiatrist for about the last year and a half. He had been started on Prozac and hydroxyzine, hadn't required any inpatient hospitalizations, but hadn't been doing well for the last couple of years, and really things had gotten much worse in the last few months. In terms of kind of concerning behaviors, there weren't any previous suicide attempts, but there had been some intermittent SI, some recent passive death wish, and an increase in recent months of self-injurious behavior. During episodes of extreme anxiety, he would hit himself or hit his head against the wall and really wasn't able to control that behavior. Additional behaviors we learned about that were concerning were in a few months prior to his presentation to our clinic, he had slept with a knife under his pillow for a few nights out of concern that his parents were going to hurt him, though both the child and the parents admitted that there had been no abuse in the home to suggest that he should be concerned. And he also described to me about a year prior to his presentation to our clinic, he had experienced some fleeting thoughts of homicidal ideation while just kind of wandering out in the community or when he would get really angry. And these had been really alarming to him, but had passed. In terms of his trauma history, his father had been incarcerated from his birth to age 5 years old. And upon returning to the house, there had been a lot of kind of familial and parental discord that my patient had witnessed. He had no current or prior substance use history. And in terms of family history, his mother was diagnosed with bipolar disorder, and she'd been treated successfully with mood stabilizers and was continuing to see a psychiatrist and therapist present day. In terms of the symptoms that he was experiencing on our interview, it pretty much covered every single category of psychiatric symptoms. Mom was most concerned that over the last 3 years, he appeared to not be himself anymore, a total lack of self-confidence and self-esteem, very anxious, especially around school. In terms of my patient's concerns, he felt that he was an outcast. Everyone thought he was weird and strange at school, and it caused him a lot of anxiety, resulting in him sometimes scratching his face in the classroom, having to get up and leave and go to the guidance counselor's office, feeling really overwhelmed. He described having panic attack symptoms pretty consistently while at school. He described having depressive symptoms like low energy, low appetite. He had lost at least 30 pounds over a period of a couple of months. Anhedonia, wasn't doing any of the things that he enjoyed doing, no longer playing video games or guitar. He described feeling hypervigilant at school, paranoid that people were out to get him at school, that they wanted to hurt him at times because they really didn't like him. And his mom described him having what she called like explosive reactions to arguments that they would have at home that were totally out of proportion to the way he normally reacted. The only category of symptoms that he didn't really relate to were symptoms consistent with mania. On that initial mental status exam that day, what was most notable to me was the kind of withdrawn nature of him as he was sitting there. It's not uncommon for like a 15-year-old who's being interviewed by a room full of people to be uncomfortable and guarded, but he was incredibly withdrawn. There was psychomotor retardation. He made very minimal eye contact. He had impoverished speech and looked to his mom to answer most questions. And though he described feeling incredibly anxious, the overwhelming sense and the affect was of being severely depressed. At that time, he didn't have any thoughts of suicidal ideation or homicidal ideation, but was describing feeling like life was just not worth living anymore if he continued to live at that level of anxiety. In discussing his case at the end of the interview with Dr. Payne, my supervising attending, we landed on some kind of definitive diagnoses for that day, which included severe major depressive disorder, generalized anxiety disorder, and social anxiety. That being said, we talked at length about, given the wide array of symptoms he was experiencing and the severity, and given his positive family history, that it was possible there was also some sort of like prodromal nature to his symptoms. So we had a pretty wide differential as well including like a trauma disorder, an unspecified bipolar disorder, OCD. There was a lot of information to collect, and it was very much just like part one of that diagnostic evaluation. So I started seeing him for weekly medication management and therapy immediately after that intake at the end of October. In the first initial visits, I kept collecting more data. We did a PHQ-9 in the beginning of November, and he scored a 24, which put him in the severe category for depression. Completed the Spence Anxiety Scale, which showed that compared to same gender and age children in his demographic, he scored greater than 98% of those kids in categories for generalized anxiety, separation anxiety, panic agoraphobia, social phobia, and OCD. So essentially every kind of anxiety. And then at that point, given the severity of his symptoms that were really kind of focused in the school setting, I reached out to his school counselor and administrative staff to get more information about what things were like for him at school. Given I was seeing him weekly, I could talk about all of the things I learned about him for like a very long time, but I'll hit the major highlights. Pretty soon after I started seeing him, there was an episode at school where he went to his counselor and told her that everyone was talking about him because he was weird, and he was concerned that they were going to hurt him. And there was some notation that maybe he had said that they wanted to kill him, but that wasn't very clear. He went to the quick clinic, the urgent care at Shepherd Pratt, and they felt that he required day hospitalization, which he completed from November into December. They transitioned him from Prozac to Seroquel at that time, I think to address the depression and the anxiety that was pretty acute. And of note, they wrote in their discharge summary that his hypervigilance was borderline, paranoid, and psychotic in nature, but not of true psychotic phenomena. When he returned in the fall and the winter to the outpatient clinic with me, he continued to describe feeling like his peers thought he was weird and strange. At one point, he told me he heard someone say that he was weird, but he couldn't really clarify to me who said it and what was the context. And his depression and psychomotor retardation remained the same. He was pretty minimally engaged in therapy, and a lot of our appointments were about psychoeducation and trying to get a better sense of his symptoms. Throughout the fall and winter, I increased his Seroquel. His PHQ-9 slowly started to improve, as well as his subjective symptoms of depression and anxiety. His PHQ-9 went to a 13. In January, depression really started to improve. He was no longer having psychomotor retardation. He was engaging with me in therapy. He was even able to like laugh and make a couple of jokes. So it was like a much needed improvement, I think, for both of us and his mom to see him finally getting a little bit better. But was still very concerning to both his mom and myself was that the anxiety remained incredibly high. He still described feeling like kids at school were judging him, were thinking that he was weird or strange. He actually told me that he heard someone say that he was mentally disturbed during one of his classes. He wasn't having to get up and leave the classroom nearly as much as he had been, and there was a lessening in the self-injurious behavior at school. So I continued to increase the Seroquel, hoping to target those symptoms. This culminated in February of him having 2 episodes at school, one where he ended up scratching his face so hard that he bled and his mom had to come pick him up. And then later in the month, him presenting to a school counselor, telling her that he needed to stab himself in the chest and he needed to leave school so he didn't hurt his peers. He actually said, "I can't stand the students' faces and I don't want to hurt them." He went back to Quick at Shepherd Pratt and was admitted to the Shepherd Pratt Teen Boys unit for the end of February into March. And they continued the nighttime Seroquel he was taking and added a morning dose to help with some of that school-related anxiety. My concerns that his anxiety, which was paranoid and hypervigilant in nature, wasn't getting any better, continued to heighten with this episode. And this all came to a head when he returned to school and his mom had a meeting with the school counselor where they were talking about the events that had led to his hospitalization. And for really the first time, his mom was able to confirm some of our concerns, which was the patient told her that people were talking about him in the office, that he was really listening very closely to hear people out in the hallway changing classes, and he reported to her that people were talking about her. She was able to confirm that she did not hear anything. No one was talking about him. No one was looking at him. And people were having quiet conversations across the room, and he was assuming that they were talking about him. So this just further heightened my concerns that at this point, maybe some of these anxieties were more of a perceptual disturbance. So at that point, I talked with Dr. Marks, my therapy supervisor, and Dr. Payne, my attending supervisor in the clinic. And we thought at this point, I had enough evidence to reach out to some consultants in the area. So I reached out to the Strive consultants, Dr. Reeves and Dr. Rukatar. We talked about my patient's case, and they recommended that I complete a PRIME screen, which is a self-report of high-risk symptoms for psychosis. And my patient scored a 9, which is pretty positive. We went ahead with scheduling a full kind of psychological diagnostic evaluation with Dr. Rukatar and Ms. Chobani, who completed that evaluation in our office. At this point, we were still titrating his medications. His depression was improving, the PHQ-9 of 8. But given he was still incredibly anxious and paranoid at school, there were more events popping up that were making it difficult for him to engage in school. And we had several team meetings and ultimately transitioned him to an adjusted schedule where he was going just half a day every day of the school year. In mid-April, patient and his family received the results from the Strive consultants of his evaluation, determining that he was experiencing psychotic symptoms. A referral at that point was made to first episode clinics in the area. I'm still not quite sure if giving him kind of the label of psychosis or if it was kind of the effects of having finally having a name for things, but it felt like there was an initial relief in some of his symptoms, having been given a name and some sort of forward movement, which was followed pretty swiftly by an acute worsening in his symptoms that lasted a few weeks. He described his peers making fun of his clothes, saying that his clothes were made of rat skin. He noted that people in the community, adults, were making threatening, antagonizing hand gestures at him. It seemed like his distress and his depression were acutely worsening, and whether that was just because he now had the language to describe that to me, or if he was feeling hopeless from all of the research he was doing online himself about his new diagnosis, it was unclear. At that point, I reached out to Dr. Richardson of the Rays Clinic to get some medication recommendations and further guidance while we waited for the referral to the first episode clinic to be made. By early May, we had titrated him to a total of Seroquel 550 daily and Risperdal 1 at nighttime, given his worsening in symptoms. By the end of May, he did a part 1 evaluation with MPRC's first episode clinic. And as of this past week, his depression scale rating on PHQ-9 went down to a 1. So clearly this was a very long case. And I think, hindsight is 20/20, but I learned a lot of lessons along the way. In terms of how I approached his diagnosis, I think that I did feel that I was flying blind for a lot of the time, especially at the beginning, given the great variety and breadth of symptoms he was experiencing. But I'm very grateful for those initial conversations I had with Dr. Payne, where we discussed the idea of this being a prodromal illness. That was, I think, an easier conclusion to come to, given the variety of symptoms he was having and his positive family history. But because of that, there had been a lot of psychoeducation with the family and the patient along the way, that the diagnoses he had been given were true to the symptoms he was experiencing right now, but that there might be some changes for him in the short and long-term future. So we talked about, what does bipolar disorder mean? What would like a schizophrenia illness look like, throughout the journey? So by the time we had moved into March and were reaching out to the consultants, it wasn't too much of a surprise to the family, and they were pretty relieved that we at least were kind of making conclusive decisions in one direction. Something that has been really emphasized to me in the last couple of weeks, especially while his symptoms were getting acutely worse after receiving his diagnosis, was that emphasizing strengths of both the patient and his family is hugely helpful. Might seem like a very small thing, but emphasizing to his mom and to the patient that, he's incredibly resilient and strong and intelligent, and he has this massive family support, and his school is incredibly engaged and supportive, I think was really bolstering when they were feeling like there wasn't too much hope and his prognosis was really poor. He's had an incredibly challenging year. He refers to it as being like the most chaotic experience he's ever had. And the fact that he's still here and he's still in school on an adjusted schedule, and his family is still there with him and the school is still engaged, I think are all really bolstering factors in his prognosis. I think most relevant lesson I've learned that's most relevant to today's grand rounds is how hugely important it is to collaborate with the people that you have available to you, especially if you have access to a first episode clinic. I worked with my own kind of in-house supervisors and his school, but I've reached out to so many people within the first episode world here at University of Maryland who have taken time to talk about the case with me, to give recommendations, to push a referral along in a really kind of speedy process. And that was really helpful to his family and to the patient, and for me as like a training resident. In terms of how my patient is doing now, really happy to say much better as of this week and today, and we're taking it a day at a time. He has some PRN medications he uses for anxiety and for agitation and for some of the symptoms that he's been having that cause a lot of distress. But he's currently getting 2 antipsychotics, with the goal being that ultimately he could get onto like a 1 antipsychotic and an LAI in the future, but it's been a journey to get to this medication regimen. In terms of his depression, it's massively improved. He's gone from a 24 on the PHQ-9 down to a 1 this past week, and psychomotor retardation is gone. His affect is a little bit broader. He's still a little blunted and constricted, but he laughs with me. We have rapport. He's able to talk about how he's feeling, and it's a much different person than who he was when he came to the clinic back in October. The Seroquel is causing some sedation for him, so that's been an unfortunate kind of byproduct of that medication, and I think he's pretty eager to make a change. His psychotic symptoms, though, weren't really getting much improvement with Seroquel, and it was the addition of the Risperdal that has made that much more quiet for him in recent weeks. Kind of a happy end to this story, which is not always the case. I found out just like 2 days ago that he was accepted to the MPRC first episode clinic, and he has an intake on Monday, which is unfortunately the same day he starts his final exams, but in like a really wonderful silver lining kind of like positive way of looking at things, he is on track to finish 10th grade and will move on to 11th grade in the fall. We were all really concerned about his ability to finish school, given that's where all of his anxiety and symptoms first were kind of started from. But he's playing catch up on assignments and will take all of his finals next week. So with that, I can pass it over to the next presenter.
I think that was a great illustration of many things, but leads so nicely into, so thank you. But leads so nicely into Richard's talk about why practitioners doing this work need to know each other and learn together. So thanks for educating us about that young person. And Richard's going to talk about why we all need to be talking to each other and knowing each other in a learning healthcare system.
Thank you, Melanie, and thank you, Dr. Quayeri. That was an excellent presentation and really speaks to your careful consideration of how to support this young man as he transitions into adulthood and finds his voice and sense of hope and empowerment in living with a pretty severe set of symptoms and getting him connected to comprehensive treatment to hopefully prevent a more deleterious trajectory in his illness. So I am, in addition to a researcher, a licensed clinician, and also have been actively involved in education and training for much of my career. So when Melanie approached me with the opportunity to come on board with the EpiNet effort and partner with someone from Hopkins, I don't know if she's with us today. Her name is Jill Marsteller. She's pretty fabulous, and folks in Pittsburgh to help build and oversee the learning healthcare system. I jumped at the chance. So what I hope to do today is talk a little bit about what I mean when I say a learning health system, talk a little bit about the structure and content of our own monthly hub-wide learning health system meetings, briefly outline some of the additional resources that we curate, and talk a little bit about how we make the sausage, ongoing strategic planning for our committee, for the learning monthly hub-wide meeting, and our use of self-evaluation tools to help improve and enhance what the learning health system does and how it does it. So what is a learning health system? Well, broadly defined, learning health systems are health or healthcare systems in which knowledge generation processes are embedded in daily practice to improve individual and population health. So that's sort of a fancy way for saying, how can we integrate in an iterative fashion what we're learning and what we're collecting to inform practice that will have benefit to the individual, to the clinic, to, in this case, the larger EpiNet and research community, as well as population health. And it also reflects, a learning health system also reflects a health system in which internal data and experiences are systematically integrated along with external evidence and best practices of what we're learning about what works best in first episode context to both inform and improve practice. And the CAB is a great example of a common assessment battery that we are using to generate a lot of data. And we'll give you some examples, and Peter will have a great one for you on how we can use those data to conduct measurement-based care, similar to how Caroline used the PHQ-9 to sort of track on an ongoing basis and feed back to the young man where he was at vis-a-vis his depression and what diagnoses were being considered to help describe his cluster of symptoms. So as you can see on this slide, there are really 4 key elements or characteristics to a learning healthcare system. First, you got to create that learning culture. You want everybody to have buy-in, to be a part of it, to feel that they can contribute to it and learn from it, share best practices. You want to use the data to improve performance, as I just described. You want to rapidly integrate knowledge into practice. For example, at one point, we used the CAB data to characterize marijuana use and summarize that at the clinic, at the state and the hub level, and sites were able to use that to get a better feel for what they might offer, enhance, modify in terms of their own attention to how to best help people make decisions about marijuana use. And where possible, you want to engage everybody in this learning health system. So you want to use the data to engage patients. We want providers to come together in ways where they can share best practices. And we also want our policy stakeholders to learn from what we're doing. So we have folks from both state mental health authorities in Pennsylvania and Maryland participate with us so that they can pay attention to what might be needed to support delivery and structures for providing this kind of coordinated specialty care more broadly. So let me tell you a little bit about the structure and content of our monthly hub-wide meetings. So we decided early on that it would be helpful if we invited providers, research staff, investigators in the EpiNet program, and our state stakeholders to join us in a monthly meeting that would include various repeating components on a rotating basis. So one of the first that we established was a community of practice. And when Melanie was describing what coordinated specialty care is, she noted that it is comprehensive and integrated service delivery, team-based service delivery by a variety of different providers, prescribers, therapists, supported employment and supported education specialists, peer providers, folks who themselves have lived mental health experience who can connect with folks to support one's recovery journey while they're in the CSC program. So quarterly, we break into virtual rooms in the Zoom context so that all of the peer specialists are in one room, and all of the prescribers are in another room, and all of the supported employment specialists are in another room. And we do a variety of things. One, we just give them free time to share best practices and problem solve and consult, similar to the consultation that helped Caroline sort of think about what to do and who to involve. There was a great way to get that peer level expertise and mentorship to help support that. Sometimes we had questions that we wanted to ask of all of the different breakout groups, and we'd then break into those groups so that the supported employment specialists, the prescribers, and the peers might, for example, all talk about initial engagement or working with families and what it means for their perspective. And then we would come back together to talk about what each of the groups bring to form a holistic and integrated perspective and how to best address some of those issues. So those have been really nice to witness, and the longer they're operational, the more folks are deriving from them, I feel, because they get to know one another. And even if they're connecting outside, even though they're connecting in the context of that community of practice, they're likely also connecting with folks they have formed relationships with. We also have quarterly site and or client presentations. This is a way for everyone to learn, for example, how each of the 23 sites organizes its services, who they serve, how they handle assessment data, how they enroll folks, what some of the unique challenges are, whether they're community-based or tied to a university. And those are just very helpful to get a feel for what other sites are doing. And more we've been spending time having providers give examples of the people that they're working with and some common challenges. And they're often very compelling. As with today's presentation, you have great combination of empathy and hope and concern about how to best enroll this young man and his family in services that are going to support his longer term recovery. So those have been very interesting for folks to share and get feedback from peers. We also, as I mentioned, make periodic use of the CAB data that we're collecting. I did give the example of the marijuana data that was used. And now that we have more CAB data, we have a little subgroup that's thinking about, well, what else can we derive from those data to inform presentations? And some of those will turn into data snapshots that we'll also post on our website, which I'll talk about in a minute. And a learning health system, as I said, also makes use of expertise and expert knowledge to inform practice. So we have a series of evidence-based practice presentations or other didactic trainings, whether it's dealing more effectively with LGBTQ+ problems or dealing with issues of diversity, equity, inclusion, and belonging, how to engage families, and what are some of the other examples that I can give you there? Back to the
big one on trauma.
Trauma is another one.
Big
Next
one.
month, we have someone who I work with in the VA system who is a chaplain and he works in mental health settings, and in particular has done a lot of work in what the VA refers to as PRRCs, Psychiatric Rehabilitation and Recovery Centers. So he's very familiar with helping veterans who are living with serious mental illnesses also think about how spirituality and religion figures into their sense of identity, the unique challenges and considerations in working with someone, and especially in the face of psychotic symptomatology at times. So that's a great example of how we can make use of expertise in a particular area. There's a data platform back to the CAB delivery called Tableau that enables folks to extract data from the CAB, both individual response data and what we refer to as site-level CAB data about their metrics and demographics and who they serve and how they're staffed. And we have one of the providers at a site who is an expert in using this Tableau platform to help mine it for individual level summaries that you can use in the context of measurement-based care, similar to how Caroline used the PHQ. How can you use recovery assessments, and how can you use depression measures and psychotic symptom measures and quality of life measures to help inform the care that you're giving to someone and monitoring that care on an ongoing basis. And Melanie also has folks in her team who are experts in getting Tableau organized for us to extract the data for research purposes as well. So just briefly to talk about a couple of additional resources. We have developed an internal facing SharePoint that includes lots of tools and resources. For example, one of the hats I wear in the VA is overseeing the national rollout of one of the evidence-based practices that the VA feels all sites should implement, ensuring, in this example, all veterans with serious mental illness have access to an evidence-based practice delivered by folks who are well-trained. So there is a particular intervention called social skills training that has a long and rich history and evidence base behind it. And one of the hats I wear in the VA is overseeing the national training effort to make sure that there are thousands of providers who are well-trained in delivering social skills training with fidelity. And over the years that we've done that, we've collected a lot of tools and resources. So those are all available both to us on the VA, and we've made sure to move those over to this particular SharePoint. For those of you with any history of SharePoint, I always notice, myself included, there's some ambivalence about using it. It's overwhelmed. It's never organized the way you want it. We're continuing to think about how to better curate it, how to better annotate it so that the resources we have there can be helpful and actually called upon when needed. Melanie and a team also early on thought it would be absolutely essential for us to have an external facing website. And the name of the website is there and the URL is there, and they're both hyperlinks, I believe, in this particular slide. I encourage you to check it out. It gives you information about each of the 23 sites, visually where they are, their resources for family, their resources for providers, for consumers. We hope to post these data SharePoints moving forward so that it's an ever-evolving resource and platform for folks to support what we see as an important learning health system. So with that, I'm going to pass it on to Peter, who I believe is going to talk about how he's used some of the CAB data. So I have to stop sharing. Let me make sure I figure out how to do that.
There we go. All right. Hi, everyone. My name is Peter. As Richard said, I'm just going to give kind of a case example for how we're using this data sort of behind the scenes to understand treatment outcomes and track progress for people that are entering treatment and going through the program.
Hello? Can you hear me?
Yes. Can you hear us? So yeah, the case example I'm going to kind of use is suicidality, just as a treatment outcome to zoom in on. We collect huge case battery or huge assessment batteries worth of data, but suicidality is one outcome that is a particular interest for the EpiNet initiative as a whole nationally and even internationally at other analog programs. The reason suicidality is receiving a lot of attention across EpiNet is that suicide risk for people with first episode psychosis is extremely high. In general, for people with psychotic disorders, there are very high rates of completed suicide. Pretty conservative estimates suggest that around 5% of people with psychotic disorders complete suicide. That's not attempting or having ideation. Those are completed suicides. So about 1 in 20 patients and non-patients can be expected to complete suicide, at least given past rates. Rates of suicide are not evenly distributed across the lifespan. They tend to peak, evidence suggests, right around the first episode of psychosis. So the period that is targeted by early psychosis programs like ours is a high-risk period for a high-risk population when it comes to suicide, making it a particular outcome of concern. Unfortunately, the evidence suggests that suicide risk often remains high even for people that are in these programs. So again, this is why this is maintained attention from policymakers and researchers and clinicians, as opposed to something we sort of assume will be taken care of when people enter treatment. Just to give some examples, I've highlighted some findings from essentially EpiNet, like first episode psychosis network analogs in other countries, and shown rates of completed suicide among participants. These orange lines are follow-up durations. So all these programs tracked people for quite a number of years and then checked how many people had completed suicide in that time frame, with the beginning time period being with people entering treatment, and the follow-up duration being usually a fixed period. In a Danish network, a pretty large network, they found that within 5 years, 1% of participants had died by suicide. In a Canadian implementation, another regional network, 1.2% had completed suicide within 5 years. In a large program in Australia, 3% of participants had completed suicide within 7.5 years. And then this, again, large implementation in Hong Kong, they found that 4.5% had completed suicide within 5 years. These are pretty high rates. Not all of these had control groups, so it's sometimes hard to know what to make of this, but some of them did. The Danish study actually found that their treatment program had no measurable effect on suicide. So that was one sort of disappointing finding, where it wasn't clear that the early psychosis services helped. There was no measurable impact. Interestingly, the Hong Kong implementation was the only other one that had a control group. They had a sort of a controlled treatment program for people. They measured an impact on suicide rates that was in the right direction. In other words, early psychosis treatment services helped. However, this 4.5% rate is the rate in the active treatment group. And to me, that seems incredibly high. So again, this is one of those things where we sort of have to pay attention to both the decrease, but also like, what is the end result that we're finishing at? And I would argue that 4.5% of people killing themselves within 12 years is not kind of like okay, we're done here. We've had an impact. Yes, this program had an impact, but I think there's obviously quite a bit of room for improvement. So this is sort of the background context in other countries and just in the treatment population as a whole that makes us very concerned about suicide outcomes and kind of focusing in on this as a network and a national implementation. We do track suicide in a number of ways within EpiNet. We have a self-report item as part of a larger inventory that tracks suicide ideation. This is a self-report measure. Clinicians will report based off of patient interviews and other sources about past 6-month ideation, past 6-month self-harm, and past 6-month suicide attempts. And then finally, we also track completed suicide during treatment. We don't have a systematic way currently, although we're working on this, of tracking completed suicides when people leave, but we do pay attention to whether people complete suicide during treatment and report on that as a program. So I wanted to kind of dive into these outcomes one by one. I guess I'm starting in reverse order because this last outcome is the simplest. When it comes to completed suicides during treatment, we have no instances of this among the data that we have for EpiNet in the context of EpiNet, which is a good sign. So no one completed suicide during treatment so far across Pennsylvania and Maryland. Self-report outcomes. It's hard to see this because honestly, there was kind of a floor effect a little bit. But this measure asks people during the past month, how often did you feel like hurting yourself or killing yourself? And it's a Likert scale ranging from 0 to 4, with 0 being not at all and 4 being at least every day. And I showed a graph of these findings for the average self-rating at each time point for people in treatment. So we're rating people at every 6 months. We're checking in every 6 months with people, and each of these time points represents a 6-month assessment. So that one there at the bottom, at the very left, is baseline, and then every 6 months afterwards. And it's hard to see here, but if you model this statistically and even visually, you can see that these are actually pretty like regular improvements in suicidality. There's a little uptick on the last time point, but the end there is much smaller. And overall, these represent statistically significant, and I would say clinically significant improvements as people move through therapy. We also have these clinician report measures. So I've graphed at each time point the percent of people with past 6-month suicide ideation on the far left. In the center, the percent of people at each time point with past 6-month self-harm. And then on the far right, we have percent of people with a suicide attempt in the past 6 months. I think with the naked eye, you can see that these are pretty dramatic improvements. There's especially large improvements within the first 6 months of treatment. So this is a population, as you can see from the data, that entered treatment with really high rates of suicidality, at least over the past 6 months, even really high rates of suicide attempt, with approximately 10% of people at baseline having attempted suicide quite recently. But as people move through treatment, these numbers drop precipitously. And these findings, if you control for sort of different clinical effects, we're seeing improvements of something on the order of 70 to 80% drops just within the first 6 months of treatment, which is really encouraging. It's interesting to kind of think about what we can do with this data and also what we can't do. And I think starting with what we can't do kind of helps us kind of conceptualize what we can do. So I thought I'd kind of walk through that a little bit. The question I had here when we look at this is like, how do we understand these findings? Like, how good are these, And I think one thing we can do is kind of compare with other treatments, right? I'm a suicide researcher. I design and implement suicide interventions. And I can say that seeing improvements like this within a 6-month time frame looks really remarkable to me. I think even in the context of other interventions that focus on suicide specifically, these are pretty substantial. But we don't necessarily know yet. We, first of all, are quite a young program. So if you kind of put us in the context of these international programs that I've pointed out, we don't have much follow-up data. So it's hard to know yet how to compare ourselves to other programs. So I think something we'll have to do is kind of wait and see a little bit and continue to track people and continue to compare ourselves against other programs that are doing similar work. Another thing we've thought about doing is comparing these findings to the general population, but that's quite hard because, first of all, people with psychosis are quite unique for many reasons, including demographically, and just for the fact that they have psychosis. That's not a very common symptom in the general population. And also because rates of suicidality change a lot over time in the general population too. So I thought it was interesting to look at like representative samples of this age population over time. And even just within a 3-year time span, rates of ideation over the past 6 months or year changed dramatically in the general population. So it's hard to know without a control group what to make of these findings. But there are things that we can do. And so I'm going to highlight some of those now. One thing that we are doing with this data is we are looking at within subjects predictors of suicidality to try to identify things that we can kind of have an impact on as clinicians, to help people improve outcomes further or support people who are struggling with suicidality. One thing in this sample that we've looked at is a bunch of different clinical factors and whether they track suicidality within subjects. So in other words, like when people get less suicidal, what tends to be happening to those people? And also the converse, when people are becoming more suicidal, what tends to be happening to those people? Again, the goal here is to try to identify factors that we might be able to help people with. This is a list of factors that are statistically significant predictors of within subject change and suicidality among people in our programs. Role and social functioning are strong predictors of suicidality. This means like being able to go to school or stay in school, having a job if you're at that life stage, and also having friends. Those are really strong predictors of suicidality. And when those worsen, suicide tends to worsen and vice versa. Depressive symptoms, positive symptom severity, losing a job or having a job, especially in that past 6 months, tends to be a pretty strong predictor. So when people have recently lost a job, that's a risk factor, but also gaining a job is a really strong protective factor. This kind of work can also help us identify kind of programmatic changes that we might want to make. First of all, I'll point out that it's interesting that all of these first, I guess, 5 on this list are things that are systematically targeted as part of the CSC program and the CSC model. So we have supported employment specialists that help people with getting jobs and staying in school. We have therapists that help people with depression. We have psychiatrists that give people medication for mental health symptoms. So all these things are sort of systematically targeted by the program anyway. And the data also suggests that these things systematically help with suicidality as sort of a fallout. So that's encouraging. But there are some things that we've identified that are not systematically targeted by the program. And one of them in particular that I'm highlighting is trauma symptom severity. That's something that, of course, good clinicians will focus on just as a matter of course. But in terms of like a systematic part of the program, that's not something where we have like a trauma, component, or like we're not doing prolonged exposure as sort of like a systematic component of these programs. And yet the data suggests that that's a pretty significant risk factor for suicide. This kind of work, identifying trauma as an important predictor using EpiNet data, helps us guide our program more broadly. And this is something that we're looking at systematically now as something that we might be able to pay more attention to as clinicians and as researchers is the course of trauma among participants in this program and how we might be able to affect that. So we've got some work groups working right now to try to better sort of incorporate trauma-informed care into these programs. Another thing that we can do with this data and are in the process of doing is comparing between EpiNet clinics. So while we don't have a control group, with like a counterfactual that's receiving a worse treatment or something like that, we do have a ton of component programs in different clinics, even within our single 2-state region, that are all doing a similar treatment model and that we can compare across each other. So in Maryland and Pennsylvania alone, we've got over 20 sites that are all contributing data to our data sets. And one thing we've thought about doing is trying to track these different clinics over time and try to identify like star players. So are there clinics that are doing an unusually good job at improving suicide outcomes? And if we identify those programs, then in the spirit of the learning health model, they can share what their secret ingredients are, what they see as important for suicidality, and what they find that they're doing well. We have, as Richard described, a lot of opportunities to check in with each other, including like I forget what the name is, but basically like we all meet and talk about, like we teach each other what we know, and if we identify standouts, we can invite those people to share. Interestingly, I've already checked, and so far there are no standouts statistically, which I actually find that largely encouraging. It means that they're not like 3 clinics that are just driving all of these suicide improvements. Instead, as you can see just sort of visually from this graph, there's a pretty general improvement across all clinics on suicide outcomes, as opposed to a single clinic that's just driving everything. Or just, we've also checked certain types of clinics, like are all the clinics that are in the academic centers doing better? No, it seems to be like across the board in urban settings, rural settings, we see pretty significant and steady improvements in suicidality. It's important to monitor this stuff using statistics versus just like raw numbers or visuals. And to illustrate that, just again, if you'll draw your visual attention towards this graph, you can see, for example, there's that blue line that just shoots off into the stratosphere. At time point 4, it shows 100% rates of suicide ideation. But actually that time point 4 is composed of a single person. So that person just happened to have suicide ideation. So that clinic looks really bad at time point 4. I'm just pointing that out as a way of illustrating the fact that these monitoring these sites sort of has to be done statistically. So it's nice that we have people in a research center behind all this, kind of like who are able to bring those statistical tools to bear, because that would be a more challenging thing to do, I think, as clinicians or people without that kind of expertise. So that is something that we're monitoring, is again comparing our clinics against each other to see if there are standouts. Finally, I just want to highlight some potential next steps or things that we're doing. One is continuing to gather lots and lots of data. That's important for being able to have robust samples to compare to other programs and comparing programs with each other. When you have a group that's N of 1, you can't really compare it to anything. So we're continuing to collect data to try to collect more robust findings and findings that we can take more seriously. We're also interested in comparing EpiNet clinics against each other continually and perhaps EpiNet regions against each other as well. New York is another EpiNet region that's also doing this kind of like between clinic comparison. And I'm interested in comparing regions against each other to see if there are regions that are standouts. Part of me suspects that we may even be a region that's a standout in terms of suicide outcomes. But it's hard to know until we actually make those comparisons. And finally, there's a million things, but another thing is I'd really like to track outcomes for people who are no longer in treatment. For example, you saw that we track suicide outcomes for people that are in treatment, but that's a limiting factor. Once people leave, we don't know what happens to them. And one thing that I'm working on currently and that we're working on is trying to better track people as they leave, both to see, like, for example, are people that are leaving early, like in a tough spot, or maybe alternatively, are people that are leaving early leaving because they know something we don't. Maybe they're not getting what they need out of the program, and they know what's best for them, and they should be somewhere else. In both cases, we'd like to know about that, and knowing what happens to people after they graduate too. These are for the most part, these programs are restricted to 2 years for people, and then we kind of cut people off. But there's some interest nationally and internationally about whether that's too short of a time frame and whether we should be keeping people in treatment for longer. And so again, it would be really nice to know what happens to these people. Our treatment outcomes were, do they persist, or do people kind of fall off, or do people just continue to improve? All these things are interesting and require some linking with data sets that we don't have access to currently, but that we're working on. So that's kind of my little highlight of how we're sort of using this data in the background to track outcomes, and I'll stop sharing.
Peter, that's an excellent example of the value added of using information in a learning health system context. I look forward to inviting you to participate in one of our monthly hub meetings to share this data, to show providers how they can use that data to inform their work with individuals, and maybe pair it with some best practices and how to address some of the correlates that support a reduction in risk, so that we're giving folks information about how to best address the importance of suicide in this context. So that's just a perfect example to end on, I think, in terms of what a learning health system is and how we can, in an iterative way, improve what we do and how we do it.
Yes, definitely. So we have a number of, so it's taken till this point, the project really began in January of 2021. We started our data collection, and it's taken a good long time to actually have data to look at. So the other reason why having Peter present today is so exciting to people in the project is we finally have data to look at, which is amazing. And as he said, we can, just now it's set up and it just continues, which is amazing. Our clinical programs, some are represented here by faces that I see, and they are really the stars of this, because without them, there's no data. So we continue to write on a number of different topics, and the goal is that any researcher that uses the data to write a paper would do two things. They would work with our team to create a one-pager, visually appealing data snapshot that goes on the website, so people can just have a little peek at something, at their main finding. And then that they would come to our hub-wide learning healthcare system meeting. It doesn't have to be an hour or two, it can be 15 minutes, present on what they did and what they found, so that the people collecting the data and who can use the findings, have access to what we're learning. So maybe that's a good time, a way to stop. 1:12, I'll zip it. But thank you for having us. This is a lot of fun.
Melanie, thank you so much. That was wonderful. I do want to open it up to any questions. If you want to type in the chat or otherwise, please feel free to speak up. I guess I have one I wanted to ask. At the very beginning, you mentioned that you make it worth the while for the sites. What makes it, what about it? What do you do to keep the sites engaged? Because you're asking them to collect a lot of data, you know, how do you do,
Let me rephrase that. My goal is to make it worthwhile for the sites. You have to ask, let's see, the two people who are in my visual field at the moment are Dr. Weiner and Dr. Hackman, and Dr. Richardson is somewhere. I saw her. You'd have to ask them if we are realizing that goal. But I sincerely hope that at some point the sites will benefit from the data they collect. So what do we have so far? We have, as I said, we have research, data people working with the data and making it, presenting it back. So that's one way we're trying to get, what are we finding? How do what questions are we asking? We have frequent meetings with the teams where we say, are there things you want us to be looking at? You don't even have, you can just come up with an idea and the data folks behind the scenes will go and look at it. I think Richard was describing, I think the main thing we were hoping, and I don't know if it's going to turn out to be good or not, is all the sites have access now to Tableau, which is a data visualization portal. So they can go in and look at their data in a number of ways, either by site or by individual young person that they work with. So if you want to show somebody how their ratings have changed over time and incorporate that into your care, which would be great. I mean, that's true measurement-based care. But I think what happens is it's just hard to start. Like there's now data, like for 2 years, there wasn't much data by now there's data. So now we're really hoping that sites will find that useful. If not, or if Tableau is just not the way to do it, then we will have to find another way. But the goal is that.
I see Dr. Weiner and Dr. Reeves have their hands up. So Dr. Weiner.
Let's start with Dr. Weiner because she's collecting data probably right now.
I'll go first. Well, I want to thank you all those were wonderful presentations. Caroline, you did a great job. And Peter, I had a couple questions. What I wanted to know, was substance abuse part of the predictive, individual predictive factors in suicidality?
So interestingly, I did check, and wasn't on the slide for a reason, because it wasn't statistically significantly related. I had a pretty blunt force measure of substance. First of all, I only checked alcohol, and I know for a lot of these kids, it's marijuana.
Marijuana, right? So
I'm gonna have to go back and check that, and it's something I realized as I was putting the slides together, and then didn't go back and check yet.
Yeah. I'm very interested in that, because I've always found it interesting that part of the coordinated specialty care doesn't involve sort of a person with substance abuse training on the team per se. So I've always felt like that was a little bit of a hole in our team. And so it'd be really interesting to me whether marijuana use has, some real impact on the suicide question. We know it does on the psychosis part, but I'd be really interested on the suicide part. And the other thing that we're really interested in which I know Sean is already doing some work, is about engagement, because actually the 2 completed suicides that we had in the last year were both people that had disengaged from our services. And of course, from my point of view, our team did everything possible that we could to engage the person and engage their family, and we still weren't able to keep them. So I think that's a really important piece that we would like more information, to help us.
Yeah, I'm glad we're connecting. I appreciate the kind of alley-oop and the almost like hint on where to look. I'll check the marijuana stuff. We should also connect about the 2 people that committed suicide, because they're not in my data set as completed suicide. But
right, I've already sent the therapist an email saying, did you connect with Peter about this?
Yeah, I'd like to tell him about this.
Yeah.
And I'm sorry to hear that, and we'll look into this, and I'll get back to you via email or something.
Yeah, but thank you guys all for the presentations and the work that you're doing. Really appreciate it.
Thank you.
Dr. Reeves, then Dr. Gorelick.
Yeah, so I have 2 questions. So one for the rising stars and one for our senior wise experts. So I'm going to start with Peter and Caroline. I have been humbled through the years at how difficult it is to assess something like suicidality in somebody who is currently dealing with psychotic symptoms. And I've had patients through the years harm themselves pretty significantly in the context of a delusional thought where they thought they were saving their life. It was not an effort to harm themselves. And then there's a lot of, there can be a lot of distortion about what that means to have intent or ideation. And so I know that we kind of assume that that's sort of a set thing. I wonder if you could talk, Peter, from a research perspective, and Caroline from your clinical work about, some of the challenges of assessing if something is really suicidality, or, what that even means. It's, and how to do what you really want to do, which is assess safety.
Yeah, it's a great question. I mean, there's the easy answer is that it's really hard, and there's not really a way to tease it apart. I think it's valuable that we have data on self-harm and attempts and data on clinician report, because some of those things are less ambiguous. Self-harm in particular, it's something that we kind of check as a box whether or not they say they have intent. It is interesting, like statistically, not with all cases, but statistically, often those acts of kind of like you might call it like psychotic self-harm often do track really well with suicidality, but it's not 100%, and I think that's just kind of a limitation. I think it partly underscores the importance of having all these different ways of getting at the same sort of constellation, as opposed to relying on any single one of them. And I'm curious for.
Yeah, I mean,
Carolyn, I know you did a lot of safety screening for this patient. Interested your thoughts on that issue.
It's been incredibly complicated, that particular issue. I mean, there's elements to his kind of clinical course that we didn't even get into, like him telling me in January that he had taken a knife to school several years ago, and then we had to kind of like change and pivot and work with the school to get kind of safety precautions in place there. So for him, it was both kind of like suicidal thoughts, homicidal thoughts, mostly being driven by the psychotic symptoms, it seemed, because it was causing him so much distress. He just wanted to be anywhere but at school, or as the psychosis kind of seemed to seep out of the school setting and started to be around like any person in the community he thought was antagonizing him, it felt like the only safe place was home. So we had to kind of strike a balance working with his mom and the school so that he didn't become totally reclusive and just stay in his room. We needed him to like engage with his life and not totally give up on everything while still maintaining his safety. So there were a lot of kind of safety precautions in place, a lot of suicide screens with him, building rapport, safety planning, being very open with mom and him about kind of like where I had to escalate care if I felt like things were heading into more of like a gray area. And that I'll admit, in the last like month since he received the diagnosis of kind of psychosis, that became harder for me because I felt like he was really kind of retreating within. And so no matter how strong our rapport was, he was becoming less kind of engaged and cooperative in sharing with me what he was experiencing. And so there was a lot of conversations around that with his mom and with his school, trying to meet him where he was, but make sure that he was safe and that all of his peers were safe, obviously, because he has some thoughts related to them as well. So one thing that I think has been hugely helpful, at least for him, was a lot of like honest discussions that we had earlier, that like we use those words of, I think I need to leave school because I'm going to hurt myself for someone else, when you mean it. As a 15-year-old and trying to prevent the school avoidance behavior, like there were some concerns early on that he was saying that to get out of school. And I think that, that experience in February he had where it was truly very, very heightened distress from his symptoms kind of highlighted that for him. And so with our rapport and his kind of knowledge of when you say those things, it leads to hospitalization, he took it seriously. And that's kind of what I was banking on as we went forward, knowing that I would never be entirely 100%.
Okay, thank you. And just very quickly for Melanie and Richard, I wanted to ask if you had any thoughts about where the field is moving in terms of doing a better job in thinking outside the box and utilizing more passively collected data to track progress or functioning or outcomes. And I think about during the pandemic, how, some of my patients who lived in their parents' basement continuously. And if I had like just access to their GPS and they left the house more than twice a week, I was thrilled. That was like our major treatment goal. So I wonder if you see any movement to try to think about how to utilize self-report data along with some other more passive collective data to reduce maybe some of the burden in data collection.
Well, I don't see much of that at the national group, each of us has embedded research, and nobody's doing anything quite like that, but there is a push to be able to more easily collect neurocognitive data. And so when we start that over the next few months, we're using a battery developed at the University of Pennsylvania, because that's who we collaborate with. But a lot of the sites are using Test My Brain, which is, you click on an app, you can do it anywhere, right? You don't have standardized delivery of the tests and things like that. And one site is actually going to try and do a comparison, have people do it both ways to see. So kind of, but not really what you're talking about.
All right. So to thank Dr. Gorelick and Dr. Richardson.
Oh, you're muted.
So intent on listening, I forgot to unmute. Before I ask my question, let me compliment you and the team. I know from reading the medical literature how difficult it is to set up such a well-integrated, comprehensive healthcare learning system. So I want to follow up. Thank you, Elaine, for bringing up the elephant in the room to me, cannabis use. So as you all know, July 1st, at least one of your two states will have legal cannabis for any reason.
Yep.
And I don't need to tell you what might happen based on what we know about the association between cannabis use and first episode psychosis and the future. So is your network taking any steps proactively, perhaps, to either minimize the possible damage or assess how much bad the damage is and so on? I mean, speaking as someone obviously who has an interest in cannabis.
Right. Well, within our network, this is a thing that clinicians really want guidance on. So our embedded research project is adapting a motivational enhancement therapy intervention to have good and useful conversations about cannabis use in heavy cannabis users. So we're in the pilot. We spent a year and a half doing focus groups and interviews and adapting this intervention, really building in psychosis content. And now we're in the piloting phase. So we're going to be recruiting 40 young people across our network who use cannabis 8 times per month or more. We have an N of 1 so far. So we have 39 more to go to see if this is a way to have it's a brief intervention and see if that moves the needle on cannabis use. But we're trying to changing the model around from, well, you need to reduce or stop cannabis use so that you do better in treatment. And we're really talking to people about stay in treatment, stay connected, stay engaged, use your medication, and then thinking the literature would suggest that if you can stay connected to CSC, your cannabis will improve. So kind of flip that a little bit. Whether we're ready for July 1st in Maryland, in CSC. In CSC, I think we're ready-ish. I can't speak for the rest of the state.
I'm just going to assume that Dr. Morano is telling me to talk right now. Not to stick my nose in and give my 2 cents, but well, first to Dr. Gorelick's point, I would say that my first episode patients already have pretty easy access to marijuana. So I don't know that July 1 is going to make a huge difference in that regard, except that I might feel a little more comfortable about where they're getting it from. But obviously that's different for everybody. But what I wanted to mention also about was the suicide issue, because I think another complexity about this time period is that oftentimes the people who are referred to our programs have had pretty traumatic experiences in the hospital to start out with, whether they were emergency petitioned and brought in on handcuffs or whatever. And so I think there's also this really strong desire to not mention suicidality for fear that it's going to end up with them back in the hospital. And also pointing out that like suicidal thoughts are often normal. And that the goal is to keep people from acting on them. And so I think another thing that we do a lot in the program is sort of talking about, and I know that Peter's into this as well, because I know that you're doing this DBT group. And so obviously that's a big part about that, but talking about the idea of like suicidality exists on a spectrum. Our goal is for you to stay alive. It's okay if you have a little bit, but let's check in like every time we talk to make sure that it doesn't get to a point where there is something more that we can do. And then reminding people that like, there are things that we can do to address your suicidality before it gets to the hospitalization issue, that's not the only outcome, in hopes that that also helps people feel safer to reveal information that they may have or thoughts they may have. That's all.
Yeah, as Dr. Richardson said, I'm a psychologist, and I actually, I ran a DBT group very recently that wrapped last week with people who are, have psychosis symptoms and high risk of suicidality. And I totally agree with that. Like you can, one thing I do as a clinician is sometimes I'll try to lay out really clearly like my own like thought process, and I'll sometimes tell people like, hey, you've already checked the boxes. I'm not going to, there's no hospitalization or wellness check coming. I just want to talk to you about this because it's something that's clearly bothering you. Like that sort of thing. You can sometimes be really, I think, clear that the dogs have been called off or are not being called, as one way to encourage people to talk to you about it.
Timing looks to be perfect. It is 1:30, so we will wrap up. And thank you very much. Thank you guys again, Bridget, for a great end to the Grand Round season. Thanks a lot. See you all in the fall.